All right. So the first thing I want to look at is just like what kind of goes wrong with muscles. So these aren't really in your path text, but they are in the PowerPoint. And I just kind of go through some of the common things that happen to muscle, kind of like when we started the skin and we looked at all the different things that happen on the skin. So spasms and cramps, those two words are often used interchangeably by most people. Specifically, a spasm is a single muscle in a group of muscles, and a cramp is like the group that does the range of motion that it's spasming in. So they usually happen in the calf, right? So it would be a spasm if it was just like one muscle, like just your gastroc, but it would be a cramp if it was your tib posterior and your soleus and your gastroc and all cramp up together. Okay, so that's how specifically it's looked at. But of course, a lot of people use those terms completely interchangeably. Okay, but to be specific, a spasm is actually a little bit more painful because it's one muscle tightening up like that. So I have included a picture from your text where we can see the pain spasm cycle that goes on. So you end up with this loop going around and around. You get a spasm in a muscle. It cuts off the blood supply to the muscle called ischemia. That causes pain. The pain causes the muscle to spasm. That cuts off the blood supply, and around and around and around it goes, right? So we call that the pain spasm cycle, and you'll see it happen in a lot of people. Obviously, you need blood to the area. So this is why whenever we're treating a spasm or a cramp that happens on the table, we just apply pressure to further occlude the blood so that blood will then rush in. The other thing you can do when people have a spasm or a cramp on the table is put a stretch onto the tissue. Okay, so it's either pressure directly in, cause an ischemia, and then let it go and blood will rush in. Okay. Another abnormal contraction that occurs, and we can take a look at them on page 171 in your text, it's actually in nervous system conditions, is the tremor. So most people, when they think of tremor, they think of Parkinson's disease. There are several different types of tremors, though. And a tremor is basically when your agonist and antagonist are no longer coordinated. So we have taken about how when the agonist contracts, the antagonist must let go to allow the movement to occur. That coordination occurs up in your central nervous system to make sure that we have all this smooth, coordinated movement. When you end up with a tremor, something in your brain isn't working right anymore. So you end up with a rhythmic, involuntary, purposeless contraction of opposing muscle groups. So you end up with basically agonist and antagonist are fighting over who gets to contract, and you just end up with a tremor in the middle. Okay, so if you look at the tremor on page 171, they do talk about Parkinson's disease. But the other one I want you to look is on the right side of the page, types of pathologic tremor. You see essential tremor. Okay, so essential tremor is not Parkinson's. A lot of people thought that Katharine Hepburn, do you remember her? They thought that Katharine Hepburn had Parkinson's, and she didn't. She had essential tremor. So the difference between the two, those types of tremors, is with Parkinson's, if they go to do anything, their tremor actually goes away. So anytime they go to move, their tremor gets better, okay, or if they go to sleep. Essential tremor is difficult to live with. With Parkinson's, it also gets worse when you're resting. With essential tremor, you don't have the tremor when you're resting, but every time you go to do something, it gets worse. Okay, so you go to tie up your shoes, your tremor gets really bad. So it's really hard with essential tremor, whereas with the tremor that is associated with Parkinson's, at least when you're doing stuff, it gets better. Okay, so tremors can be very fatiguing because they use up a lot of your energy just maintaining that tremor. So people that live with tremor have a lot of fatigue, and it's essential to know which type of tremor they have to see how you can best help them. So with essential tremor, you want them to be resting on the table because they won't have the tremor then. With Parkinson's, you almost want them to be trying to grip something or hold something or go to sleep, because then their tremor will go away and you'll be able to really flush the tissue out. Okay. Another couple that people get confused are fasciculation and fibrillation. So when you talk about the heart, you probably heard about defibrillation, right? So you have a defibrillator to stop it from fibrillating. And that's what's on 262 in your textbook. So if you go to page 262, is that where it is? How come all of a sudden that totally looks wrong? Did I put the wrong page? I think I did. Okay, where's heart conditions? That's where we'll find it. Sorry, guys. Let's find that defibrillation. Can you hear me sighing? I'm terrible. Okay. Infarct. Fibrillations, page 281. Sorry, guys. I'm going to fix that right now. And show. Okay, 281, you can see fibrillations. They are rapid, incomplete, weak attempts at contraction of the chambers. Okay, so basically fibrillations are deeper, like in the heart, okay, but they also happen deep in skeletal muscles too. You don't usually see them, but you can palpate them, and they usually occur in a lot of different neuromuscular disorders. For instance, ataxia. You can feel a lot of both fasciculations and fibrillations in ataxia. Okay, so it's not visible under the skin, it's deeper, but you would be able to feel the twitching of the muscle deep within it. Whereas a fasciculation is a brief twitch of a muscle, but it is visible. Most commonly, you would see this when people's eyes start to fasciculate. You know, when your upper eyelid starts to spasm a bit, that's a fasciculation. Okay, has everybody had that at one point or another? Usually when you're really tired, you have a fasciculation in the eye, and it's really annoying. Yeah. Okay, so fasciculations specifically are things that you can see, and you will see the muscle having that little bit of contraction going on. Whereas a fibrillation, you would have to palpate that. Okay, or again, we're familiar with that from the heart because it starts to fibrillate, which of course is not a good way for the heart to contract. So they need to defibrillate it, get it back to normal sinus rhythm, right? A tic is a spasmodic twitching. It's involuntary, and it has a psychologic origin. So the first symptoms often of Tourette's is usually facial tics, such as eye blinks. Okay, so a tic, sometimes like people will look like they're winking at you, and often they do get confused for that. It's really frustrating for them because it's their tic, and then people think they're winking at them, and you know, it just gets weird, right? So there is a psychological origin, which doesn't mean, you know, that they have a mental illness. It just means something's happening in their brain making them do this tic. Okay, and Tourette's, for those of you that don't know. Oh, okay, yeah. Sometimes they do get worse with some meds. Tourette's is actually when people vocalize. Okay, so a lot of people with Tourette's, and I don't know why, but I've seen this happen in Alzheimer's as well. It's a swear word just comes out for no reason. So that's, again, something's happening in their brain making them do that. But it usually often can begin with a tic. Okay. This one's fun. myoclonus. You finally have a name for that little sleep jerk you do just before you go to sleep. Sometimes it's so intense it wakes you up. Okay? Have you ever noticed those ones? My ex used to, you always knew when he's about to go to sleep, he had that little spasm almost every night just before he fell asleep. Sometimes people have them so bad that it actually wakes them up again. Okay? And the term that's used for that is myoclonus. Okay, so what they feel is happening when you have that sleep jerk is that when you go into REM sleep, your muscles actually all lose tone. Okay, if you've ever picked up a sleeping child, you know that. Okay, and so just before you lose that, it's like the muscles have one last little contraction just before they all kind of, get turned off for a while. And so they don't know why it happens to some and not all, and some of us it only happens once in a while when we're really tired or so, but it is termed a myoclonus. As we know, another term that we use often is hypertonicity. So this is having an abnormal increased tension in the muscle. Okay, so let's take a look at what's happening there. So here you can see the neuromuscular junctions with all the individual skeletal muscle cells. So last week, I introduced chapter 10. And what we have to get used to thinking about now, oh, hang on, I have to blow my nose. At least this time it's not allergies, it's an actual cold. Anyway, so what we have to get used to, remember last week I introduced how muscles were just wires inside wires inside wires. Okay, well the individual muscle cells all got a single axon coming to them. It's called the neuromuscular junction. And so one motor neuron, like an A alpha motor neuron, will come down and branch off to go to several different muscle cells. And so we learned last week that, remember, the fascicles were structural, so you're not going to have all the same. So if this is a fascicle, which it is, you can see the different motor neurons are coming down to the cells. So it's not going to be that they all functionally work together. They're just wrapped up in a group structurally. Okay, and then we see different motor neurons coming to the cells inside there. So one motor neuron and the muscle cells that it goes to is called a motor unit. Okay, so when we look at hypertonicity, what's happening there is not strength, okay, because strength would be these motor units taking turns to keep up a weight or hold a squat or whatever they do. They take turns, right? So everybody carries the weight. Nobody gets over fatigued. Hypertonicity is an overfiring of a motor unit. So, if we only have the two here, it would be motor unit 1 overfiring, constantly firing. That's hypertone. Okay, so the same cells are being stimulated over and over and over again. Okay, so that's hypertonicity. You have just a few overfiring and others not really being used at all or being used sparingly. And it's very fatiguing. It's very hard on your muscle because they're not taking turns like they should. And so we can use techniques to get, the overfiring ones to calm the heck down and get everybody taking their turn again so the muscle isn't so fatigued all the time. Okay, so hypertonicity isn't like you work out and increase the tone. If you work out, you increase the tone in your muscles, and it's not dysfunctional. That means that these motor units are all interchangeably working together to keep up that tone in the muscle. That's normal increased tone in a muscle, which is healthy and good for your muscle. Hypertonicity is an overuse of certain motor units. Okay, so you have an abnormal increased tension, not increased tension, which would be building up your muscles and making them stronger. Hypertonicity and that are not equal. Okay. All right, so the first condition we're just going to quickly look at is muscular dystrophy. Okay, so you'll find it on page 72 in your book. So as we learned about too in physiology last week, we learned that there is this structural type of protein called dystrophin. Okay, so here you can see these little green balls in this picture? That's that actin. Okay, remember it's the myosin pulls on the actin toward the center of the sarcomere. Okay, so this is dystrophin. Dystrophin is attached to the actin, and then it has many different types, like in the subcategories of dystrophin, that attaches it to first the inside of the cell membrane that goes through the cell membrane, and then out into the endomysium, so that when actin is pulled on, it also moves your tendon. Okay, so dystrophin is the linker protein, but it's very complex, as you can see, right from the attachment site to all the different amino acids and different subtypes of dystrophin that have to go all the way through. You end up with different types of muscular dystrophy because this is what they're lacking. Okay, so a group of several closely related neuromuscular diseases characterized by genetic anomalies, and that would be with the dystrophin, that lead to the degeneration and wasting away of muscle tissue. Okay, so you take away the dystrophin, are you going to move joints with your muscle? No. You need the dystrophin to attach the actin out into the structures that end up pulling on the tendons and then pulling on the bones and moving the joint. Dystrophin's the connector. So your muscles will atrophy if you don't have a connector. They're just basically inside your cytoplasm, and proteins are moving. Well, that happens in all your cells, right? To be able to actually cause movement of the musculoskeletal system, it has to be attached, and it's dystrophin that does that. Okay, so it's kind of important. I like how they say dystrophin is a critical muscle protein and acts like a molecular shock absorber. That's kind of a cool way to look at it. Okay, so when you look at your book, you can see there are different types of muscular dystrophy, and we'll be talking about a few of them. Okay, so you can see on page 72 types. Duchenne's muscular dystrophy is obviously, that's the most common type. Okay, that's the one that kids have. I had a cousin with MD. They generally, nothing has changed in all the decades that they have been raising money on the Labor Day weekend for Duchenne's muscular dystrophy. Nothing's changed. They still pretty much will pass away anywhere between 25 and 30. Okay, sometimes sooner. Okay, so they're still trying to figure it out because obviously your diaphragm is a skeletal muscle, like all of your muscles are eventually affected. Okay, myotonic at the top of page 73 is the second most common form. It goes through the generations of a family. So first it starts off with the oldest part, and then the next generation it'll start a little younger, and it goes through the generations like that. Okay, so there are different types, and we'll take a look at all of those. But this is your introduction to muscular dystrophy. Another condition which isn't even actually in your book, but you'll get information in the PowerPoint, is myasthenia gravis. And the only reason I cover it is not because it's super common, because it's not. Okay, but it is an autoimmune disease, but it involves the neuromuscular junction, and I think that helps us understand how it works. Oh, really, Liz? Good. When we have class on it, you can share stuff and help us understand it. Then that's perfect. I mean, that was where your dad had it, but you can like help us understand, which would be great. Thank you. Okay, so it's autoimmune. You guys remember from the lymphatic system that we make antibodies, right, with our immune system. Well, with myasthenia gravis, they make antibodies that bind to the receptors for acetylcholine at the neuromuscular junction. So that means, like, normally you release acetylcholine, it binds to the receptors, and it causes an action potential down the muscle, and you have muscle contraction. with myasthenia gravis, the antibodies cover the receptor sites. So you either have very weak contraction or no contraction. Okay, so I think it helps us understand the neuromuscular junction. So that's why I include myasthenia gravis. I don't think you'll run into it a lot. Sometimes it just affects like the eyes, and sometimes it's a little bit more serious. So another condition we're covering, which is actually from way further in the book, 318. I'm going to blow my nose. Everybody find that page. All right, lupus. A few years ago, we had a student start school, a young mom, and actually she wasn't quite a mom yet, and she had just got married, and she started feeling not very well. She was in her first year, and she ended up getting the diagnosis of having systemic lupus erythematosus, and she had to quit school because she also got pregnant at the same time. So I just saw her. It looks like she's going to be coming back for an event, so that was nice to hear. She's sort of got it all under control now and is living her life and wants to come back to school and finish her massage therapy. So I was really happy to see her. So with lupus, you can see the characteristic rash across the face here. Okay, that would be the typical discoid type of lupus. It really just affects the skin. I mean, which isn't nice to live with, but that is what, you know, the singer Seal that was married to Heidi Klum? He sings that song about a rose, you know. Anyway, Seal, that's what he has the marks from on his face. Kiss from a rose, there we go. Okay, so that's why he has those marks on his face, is from discoid lupus. Okay, so that's just a skin condition, and it's not really life-threatening. It can develop into the more serious kind, though. And so you can see on probably page 318, SLE, systemic lupus erythematosus, very serious. Okay, so SLE, I've treated people with it. It's very serious, and most people will end up passing away from kidney disease because of this autoimmune disease. So basically what it's doing is it's a connective tissue disorder, and your body is actually attacking the walls of your blood vessels. So obviously that's not going to result in very good things happening to you. So lots of things, they can have strokes. One woman I worked on had to have one leg amputated because there was no circulation left. So a lot of different things can happen. It's kept under control usually with steroids, like any autoimmune disease, but that can lead to its own problems. Okay, so we'll be taking a look at lupus, both the discoid, which is real quick, it's just the skin condition, and the full-on systemic lupus. Another condition actually from the lymphatic system is chronic fatigue. Now, why do we cover it here? Well, because of a big thing. The most consistent non-fatigue symptoms are poor memory, concentration, and post-exertional pain. So when they use their muscles, if they try to exercise or something, which they're encouraged to do, they have a lot of physical pain in their muscles and stuff. So I put it in here because that's what we would deal with the most, is the soft tissue pain. Okay, so CFS, or chronic fatigue, when I was young, back in the 80s, they called this the yuppie flu. It was a very negative term to use for people living with this because it's a syndrome. As we're going to see with fibromyalgia, a lot of people get told it's in their head. That may be true, but every thought you're having right now is in your head, I'd like to point out. You know, basically you are in your head. You know, like every thought you're having, every feeling you have, every movement you make comes from your head. So chronic fatigue, they're not sure what's going on. They have lots of different theories. Again, you can see now that they sometimes suspect Epstein-Barr virus, which causes mononucleosis because um, the signs of mononucleosis and chronic fatigue are often similar. You betcha, Leilani, yeah, pain is in your head. Everything's in your head, like everything. So, when somebody says, well, it's all in your head, yep, it is. Everything's in your head. Okay, so chronic fatigue, and I'll talk about this when we take it in class, with fibromyalgia, because they're both syndromes. I think a lot of people get a lot of grief when they live with that. And I think that's sad because I've said it before and I'll say it again. We have a treatment room, not a courtroom. We're not there to judge. We're there to help people and hopefully help them live a more productive, quality life. And so I think we could just help them as best we can. So chronic fatigue, although not really a muscular condition, does give them some muscle pain. And so we're going to look at it from that aspect because that's the one we could help with a bit. So speaking of fibromyalgia, okay, it's a multifactorial condition involving problems with neurotransmitter and hormone imbalances, sleep disorders, and ultimately chronic pain in muscles, tendons, ligaments, and other soft tissues. So this is definitely a soft tissue condition. One thing I wanted to bring up, and I just have to do this. I've put the link here for our Canadian Arthritis Society. So I'm just going to pull that up for you right now. Because a lot of people will say, oh, fibromyalgia, it's not a real condition. So what I kind of want to point out is right here. Okay, the Arthritis Society, fibromyalgia. Okay, so it starts off with home, understand arthritis, types of arthritis, and they include fibromyalgia under their banner. Okay, so this is the Arthritis Society in Canada recognizing fibromyalgia and how to live with it with a better quality of life. Okay, so when you hear people saying like it's just in people's heads, and there's a lot of recognition now of fibromyalgia and how to live a better quality life. So I put that link right in the PowerPoint, which will go up after class. Okay, so fibromyalgia is another one of those that many people that have it are very different. You'll have one person with fibromyalgia that loves a lot of pressure. You'll have somebody else that only likes very light touch. You'll have some that love heat. You'll have some that can't stand it. So it's very different. You have to do a really good patient consultation, client consultation, to understand what they need for their particular form of fibromyalgia, because people will be so different. You'll see in conjunction with it sometimes chronic fatigue, excuse me, irritable bowel syndrome often come in with it. You'll see on page 303 there, they might have chemical sensitivities. Interstitial cystitis is problems with your bladder. TMJ syndrome, so problems with their chewing and their jaw. So, oh, sorry, I'm still on chronic fatigue. Okay, let's go to 223, Sheila. They're similar, though. Okay. We will be talking about, if you look at the tender point map on page 223, those are consistent. It doesn't matter where you look that up. You'll find that tender point map. Sorry. And you will find those, they're very consistent. Thank you. But just so you know, those are not points to treat. Okay, these are just tender spots not trigger points, tender spots that appear with pretty reasonable consistency in people with fibromyalgia. So you could press on that and cause them discomfort, but it's not actually a spot where you would want to do some deep work to try and get rid of it, because they're just these consistent tender spots with this condition. Okay, so we're not trying to treat those. They aren't trigger points or something like that. They're just these spots that seem to elicit pain consistently in people with fibromyalgia. Okay, so you just have to go a couple of pages, and we're going to find out about headaches as well during this section. Another reason I have this in this soft tissue section is because the headaches that we can treat usually caused by soft tissue. Okay, so muscle tightness, different trigger points, temporal mandibular joint disorders, subluxation or misalignment of the cervical vertebra, which we can help with, eye strain, poor ergonomics, and ongoing mental or emotional stress cause the tension type headache or the fibrocytic headache. So here you can see some of the little tiny muscles, especially the suboccipits, are guilty for a lot of different headaches. Okay, you could, if you showed the face, you would see the frontalis and the temporalis often would be very tight in people living with tension headaches. We can see the different causes there, so learning assessment and stuff is going to help us be able to figure out what's going on. So you would learn cervical assessments. You're going to learn all that in advance, but for now, just in May, I would like to just show you some suboccipital decompression that we could do to treat those suboccipits, to get those to relax a bit for people with headaches and stuff. Now, in advance, you'll learn about how they can become dysfunctional when people have a car accident and stuff, and you'll learn how to more specifically treat them. But I'm just going to show you just generally how to release the suboccipits to help alleviate headache. We'll also do some facial massage to get the frontalis, the temporalis, and other muscles involved in regular tension headaches. These can be so bad, though, that people will call them a migraine just because it's a really bad tension headache. It's pulling so much, but they aren't a migraine. A migraine is very specific. So speaking of that, okay, when nerves are irritated, a complex cascade of reactions occurs that lead to a vasoconstriction followed by a vasodilation. Okay, so migraines are on page 227. Okay, so what are some of the common triggers for migraine headaches? Can you look that up there? Hormones, you betcha. All the good stuff. You notice this? Well, pregnancy and menstruation I don't know about, but food sensitivities, red wine, aged cheese, chocolate, exercising, not sleeping enough, stress. Elena, I would say dehydration is more common for a tension headache. Okay, that's probably the #1 cause of tension headaches. With migraines, what happens is this is a vascular thing. So people often get an aura. They know their migraine's coming, and this is the vasoconstriction state of their migraine. And so blood supply is cut off to the brain. Okay, so they get this feeling like, I think I got a migraine coming on. And so then what the brain decides to do is, hey, we got to get blood to the brain. So it like way over vasodilates those vessels, and you get that pounding that comes into the head of all the blood rushing in. And then what happens with migraine, okay, so here's all the triggers for it. But what happens with migraine is now all that blood rushing in makes you really sensitive to everything. So a lot of your senses are on like high alert. So smells and sound and light and anything is just too much. Most people with a migraine want to crawl underneath the covers and hide. Okay. Do we have anybody in class that lives with migraines or has had a migraine or two? I've had 3, enough to know I never, ever, ever want another one. Okay. Yeah. Okay. So yeah, migraines are the ones where you could never, ever um, like deal with lights and sounds, and you just really want to go somewhere in a dark room where nobody talks to you. Okay. So migraines, we don't really do a lot for migraines as a massage therapist other than to help a person in between them to not have them as often. Okay. Now, I just want to be clear. A lot of people will call their tension headache a migraine because it's really bad. Okay. And that's fine. But a true migraine, I don't think you see too many people being able to go out and about and do things with a migraine. It's probably a really bad tension headache, not saying it doesn't hurt and that it's not horrible. But migraine is all about the blood. Okay, first it vasoconstricts and then it vasodilates. All right, a true muscular condition is dystonia. Did I show you guys the guy that danced away his dystonia? Okay, I'll make sure I show that to you at our next seminar. So if you look at dystonia on page 166, 167, you can see a couple of pictures of people with torticollis. The woman at the bottom there has torticollis. Dystonia is repetitive, involuntary, sustained contractions of skeletal muscles. You have no control over them and they just kind of lock up. Okay? If you want to link it to neurophys, we're starting to learn about neurotransmitters next week. If you look on page 166 at the bottom, you can see some of those neurotransmitters that we'll be talking about, some descriptions of them there. So you might want to put a little marker there for yourself for looking up some neurotransmitters for neurophys, because you can see some of them listed there. Okay, so dystonia is extremely uncomfortable, and I have this video where a guy learned that movement is the way to get over it, and so he dances. And I think you'll be surprised to see what happens. And so for a lot of people with dystonia, the treatment is actually to really get moving to a rhythm. Okay. I also, when we take Parkinson's, there was, you might have seen it, it showed up on Facebook for quite a while there, life hacks for people with Parkinson's. And again, it was like you use a different part of your brain doing certain different things, and it can actually make your condition sort of go away temporarily. And so with the life hacks for Parkinson's, it was make the floor look like stairs, because on stairs they don't have trouble walking, it's on flat surfaces. And so if you make the floor look like stairs, it brings in that other part of the brain that it's not so hard for them to walk. Okay, dystonia, they're just locked right up and they can't move. But if you put on their favorite music, all of a sudden they're moving and everything's just grooving and fine and going because you bring in a different part of the brain into the movement. And so it's really interesting. So we'll look at the different types, but torticollis is the one that definitely I've seen the most of dystonia. Okay, and then you see some of that rigidity and stuff occur in other conditions. All right, now we could have taken this in joints, and I know it was mentioned in there that we took a look at it. But TMJ dysfunction, and I think I've told you my pet peeve is when people say they have TMJ. Okay, yeah, and I have knee. It always like, so you have the joint. You know, we all have the TM joint. Okay, do you have a problem with it, a disorder, a dysfunction? Okay, let's talk. But yeah, I have TMJ. Okay, I have knee. I have shoulder. Anyway, my pet peeve. Anyways, and it's an umbrella term for different problems with the jaw. So here you can see the mandible, and here we see the temporal bone. Now, when they articulate with each other, there's a huge space in between the two bones. Remember when we learned about synovial joints, right? They have a space. Well, this is a huge space. So the body puts a meniscus in there to fill a cartilaginous disc to fill that joint. But as you can see right here, this muscle here is called the lateral pterygoid, and it's actually attached right to the disc. So when you grind your teeth a lot, bruxism, clench your jaw when you're mad, this muscle goes into a state of spasm and pulls the disc out of alignment. Okay, now what happens is you get that clicking and popping in your jaw, so much so that can even lock up on you once in a while, and then you can't close your mouth. Okay, because it gets jammed in there, and you get your jaw locked open. I actually had that happen in class. Oh, absolutely. Yeah, the disc gets all kinds of damage. You can see you end up with arthritis really in the joint. There's quite a few people that have trouble with this joint. Okay, so we'll be talking about the muscles that actually help to contribute to this problem. And again, in advanced, when you take cervical conditions, you also learn how to treat TMJ conditions, because you can't really completely fix TMJ dysfunction without actually assessing and treating the cervicals, because they all work together. So I'm going to show you just how to work the masseter and the temporalis a bit, just to ease some of the discomfort. And then when you get to advanced, you learn how to assess the cervicals, then go in the mouth. We go in the mouth with a rubber glove and treat some of the muscles that are inside your mouth or just too hard to get to from the outside. So we actually have to use our finger inside the mouth to create something to work against. So it's kind of fun. I always have enjoyed treating TMJ dysfunction because you get really good results. A lot of people, it is really just from grinding their teeth or a cervical problem that they had from a car accident, which led to a misalignment of the TM joint. And so being able to help people that are having trouble chewing their food and stuff, I mean, food is kind of necessary for life. So helping people sort of get their lives back is a really good feeling. I was also really lucky that I was able to attend a seminar, this quite a few years ago, but it was dentists, chiropractors, physios, massage therapists, like all the different people who treat TM joint disorders. And we had like a one-day little seminar of how everybody approaches it and how we can better work together to help people with it. So it's a considerable problem for a lot of people. So I was really lucky to attend that one-day seminar, and I learned a lot. It was really interesting what everybody does and what they're aware of, and yeah, so quite a common thing going on. All right, we learned about contracture, right? There's contractions, which is when you contract your muscle, but a contracture is actually a thickening of the fascia. Okay, so in the case medical contractures, which we're taking right now, pathological contractures, are different than the contractures that we talk about in massage therapy. Okay, so the ones that you read about in your practical manual about contractures are things like adhesions and then larger adhesions and stuff like that. When you talk about a contracture in medical terminology, you're looking at what you see right here, Dupuytren's contracture. It's really hard to say. Okay, so on page 116, I've treated a couple people with this, and it's Dupuytren's, at least that's the way I've always said it, also called palmar fasciitis. So it used to be more common in people who worked with tools, but we have power tools now. But when you used to always have to like use your screwdriver and use your different tools with your hand like that, the If you pull on your own palm right now, okay, you can sort of see how the pinky and the ring finger do pull in when you pull on the palmar fascia. Okay, and so what I saw, the reason I've treated a few people with this was because in long-term care, this would be people who have been in a wheelchair for a long time, but they can push themselves around, work the wheels, and I saw this sort of shortening of the palmar fascia from having to work a wheelchair. But it used to be people who had to work with their hands a lot, especially people who use tools. But like I said, power tools have sort of made that be less, I would think. So what is the medical definition of contracture? And you'll find it on page 621. Thank you. Okay, so an abnormal contraction or shortening. I was typing fast when I did this. Let's fix that right away. Or shortening of a muscle, and it can become permanent. Okay, so this is just when all that fascia shortens. Okay, so that palmar fascia in your palm, okay, can shorten up, get thicker. You'll find little nodules in it. Okay, and it can become permanent if it's not treated. Guess what? Massage can help with that. Okay, tendinopathies, we could have covered with joints. We did a little bit, but tendinopathies is an umbrella term that covers injury and damage to tendons and tendon synovial as our W5. Oh, no. Yeah. With your, I know what you mean now. Sorry. No, those contractures that we talk about in massage are more like adhesions and things like that that occur in muscle when there's muscular damage. So just some of the fascia gets sticky and stuff. So when we talk about contractures in massage, they're different than these medical ones. Okay, so usually we're looking at in pathology like flexion contractures that occur after paralysis, and okay, well that's all of your mechanical effects of massage. I always say, like where I worked, that's most of what I did. Your neurophysiological kind of goes out of the window when you have people with neurological disorders. So you have to focus on the mechanical effects of what you apply. Okay, so more like breaking up adhesions and working through the tissue. It's all hard work is what it is. Okay, so you can help to elongate some of that tissue, break it up a bit, but it's darn hard work. And so, and if you catch it early enough, hopefully it doesn't become permanent. The person obviously has to do a lot of stretching, and foam rollers would be good for that and stuff like that. But contracture can become permanent, like some of the flexion contractures that we see occur in people that have different types of paralysis. Okay, so that's totally different from the ones in massage. Okay, tendinopathies are, I like what she writes about it in here. So, because there's tendinitis, there's tenosynovitis, there's tenovaginitis, there's all these different types of tendinitis. And it all comes down to they're actually tendinopathies. So it's just damage to the tendon or the tenosynovial sheath, tears, ruptures, but most problems with tendons are all about RSIs, repetitive strain injuries. Okay, aging, of course, nutrition, and other factors. So you can see here where you're getting all these little tears and stuff in a tendon. So the types of tendinopathies covered in the text you'll see on 142 and 143. There's quite a few. Okay, so I'm just going to pull them up for you. Okay, so there's tendinitis, which would be inflammation of a tendon. Tendinosis. Okay, so if you look at tendinosis, you have a long-term degeneration of a tendon. Okay, tenosynovitis. Okay, this is where it's the synovial sheath. If you recall, that's around the joint. So as a tendon goes by that synovial sheath, it's causing trouble. Trigger finger, my mom has this one from knitting. Okay, the ring, middle, and little fingers are affected most often. It becomes stuck in flexion. Like I said, my mom has trigger finger from knitting. Hope I don't get it. And of course, de Quervain's tenosynovitis is all about your thumb. Okay, guess what we might be a little bit prone to? We don't use our thumbs correctly. De Quervain's. Okay, so those are the ones in the book. There's a ton of different ones. People, they love naming them all. So it kind of drives us nuts, but you'll get used to it like the rest of us did. All right, compartment syndrome. Let's take a look at that one. Okay, it's just what it sounds like. Oh, so tennis elbow and golfer's elbow would be forms of tendinitis. Okay, have you guys taken the forearm muscles yet? Okay, all of your extensor muscles of your wrist and your fingers, okay, they all attach to the lateral epicondyle at your elbow. So remember, lateral, you have to have your palms facing forward, okay, to have an anatomical position. So the lateral epicondyle, the outside of the elbow, all of your extensors attached there. Okay, that's what we would call tennis elbow. And then all of the flexors, so all the ones that flex your fingers and flex your wrist, all those flexors attach to the medial epicondyle at the elbow there. And that's called golfer's elbow. So lateral epicondylitis is tennis elbow and medial epicondylitis is golfer's elbow. Okay, so they definitely come into play. All right, so compartments and, oh, I know, they come up with all kinds of stuff. So compartments, as you know, muscles are in compartments. I always like to think about, I don't really like when you get the leg from the turkey because of all the compartments. Just related to food, Sheila. Okay, so some of those compartments can tighten up and create a very tight fascial compartment that can actually starve and kill your muscles and nerves within that compartment. Okay, so acute compartment syndrome really needs a doctor, okay, because you can actually have that tissue die, and yeah, you're in big trouble. So acute compartment syndrome is a medical emergency, needs to be treated. They're going to have to, sometimes they just cut the compartment to release the tissue so it can get some circulation. But what is chronic compartment syndrome? What's a term you have heard about somebody, a common term used when people start to run, they complain about this. You got it. Yeah. So shin splints is chronic compartment syndrome. It's much less serious. It's related to repetitive athletic activity. Most commonly we hear it as shin splints. Okay, so acute carpal tunnel, I guess so. The only thing about carpal tunnel is that, like, it could be a bit of a compartment syndrome, but it's really about the compression of that median nerve, right? So they focus more on the nerve with that. Okay, so with chronic compartment syndrome, we can actually help a fair bit. There's only one thing we have to be aware of, and we talked about fractures last month. Stress fractures are common with shin splints in the tibia, so we're going to have to be aware that they could have some, what did I just say? Oh, I'm losing it. Stress fractures. So we'd have to make sure that those aren't there before we try to treat. Okay? I know. All right, another condition we're going to talk about is plantar fasciitis. A lot of people live with this, guys. So it's involving the plantar fascia, which is on the bottom of the foot, from the calcaneus to the proximal phalanges of the foot. Okay, so a lot of people wake up in the morning with plantar fasciitis, and they have trouble walking when they first wake up. Okay, so on page 122, she goes into a little rant. She's kind of like me that way. Okay, why should this condition, why, oh, Sheila. Hey, by the way, guys, I did get a new mouse. Did you notice my mouse is working good? I got a new one. I got sick of that old one. So why should this condition be more accurately termed plantar fasciosis, which nobody calls it that. Okay, but she says it right under plantar fasciitis because it's not inflamed all the time. Okay, it's really the degeneration of the collagen. Okay, so here's what I recommend for plantar fasciitis, or more correctly, plantar fasciosis, is that when somebody wakes up in the morning and they have trouble, it's as soon as you like plant your foot, right, it's going to stretch it out and it hurts like heck when people get up in the morning. So what they should do is have a warm 500 ml pop bottle, or if they even kept their rolling pin beside the bed and just roll their feet a bit in the morning. Better with a warm 500 ml pop bottle because it warms it up too. And just get those collagen fibers stretched down a bit before you plant your body weight on it. And it won't hurt so much. Okay, so just warming up the foot. And then as the day goes on and they get some discomfort in the bottom of the foot, take a frozen or slushy 500 ml bottle and roll the foot on it. Yeah, I know they don't usually keep a microwave, but like even if they just kept the rolling pin beside, right? Or they could have a spouse that would warm up a bottle for them and bring it. It happens. I don't know anything about that, but you know, there's other people, you know, kind, considerate person who doesn't want you like pretty much like not able to walk in the morning. Okay, so that's what I always recommend to people. Like even like I said, a rolling pin, if you're alone and nobody can bring you a warm bottle, and just roll it and warm it up a bit before, like I said, you put all your body weight onto the bottom of that foot. Okay. Thoracic outlet, page 134. You've probably already come across this in people you've been treating. So it's termed a neurovascular entrapment. Okay, so I have the picture here. Okay, that's on page 135 there. You can see that the blood vessels and the brachial plexus has to run through a pretty tight area there. So either just the brachial plexus or the blood vessels start to get impinged and cause trouble. Okay, so what are the 3 places that it can get trapped? Or they can get trapped? Pec minor can do it, you betcha. Anterior middle scalenes, you betcha. Scalenes can entrap it. You can see them in the picture. One more, there's 3. No, not the elbow, the clavicle. Yeah. Okay, so the anterior middle scalenes between the clavicle and the first rib. Okay, it's a pretty tight area right there. And then under the coracoid process, which, you know, that's the pec minor. Most often, for me, what I've seen, it's either the scalenes or the pec minor. Oh, excuse me, I'm sorry. You can see it, not as commonly, but sometimes people can have a, thank you, can have a cervical rib. Have you ever heard of that? Thank you. So has anybody ever heard of a cervical rib? That's when the transverse process for C7 can grow really long. So here's C7. So if that transverse process was really long, that could compress in there as well. Okay, so that would be a fourth cause, but it's not near as common. Okay, these three are pretty common causes of thoracic outlet syndrome. Okay, so what you're going to see is numbness and tingling down the arm. It's going to feel really heavy. You ever slept with your arm above your head and you wake up and it's completely numb? You can't feel it. It feels like it's 300 pounds. Okay, that's like living with that all the time. Okay, that's thoracic outlet syndrome. The easiest way to tell if the blood vessels are involved, we have all kinds of tests and we'll talk about them, but it's just to take the two persons' palms and look at the palms of their two hands. The hand with the thoracic outlet syndrome, if the blood supply is compromised, will be pale compared to the other hand. So it's a really quick way to know if the blood vessels are also entrapped. If they feel any numbness or tingling, we know that those are nerve impingement signs and symptoms or symptoms. Okay, so you already know the nerves involved because they're complaining about the numbness and the tingling. If you want to know if the vascular is involved, just look at the palms of their hands and you'll see one is lighter in color, more pale. And then you'll know that the blood vessels are also involved. Okay, so we'll talk about that one. Another condition we'll look at, and we'll look at a lot of these, but here's a piriformis syndrome. Okay, is a problem with the sciatic nerve. It's an impingement. So sciatic injury is any peripheral neuropathy, would be any impingement on a nerve. So it could be the sacrum, it could be a lot of stuff, but right now I'm mentioning the piriformis, putting compression on that big sciatic nerve. Okay, so sciatic injuries are on page 130. Okay, so there's lots of different reasons why you would have a sciatic injury. A lot of the time they link it directly to disc problems in your back as well. This is why you guys learn well leg, straight leg testing, stuff like that, is because of the complexities of what happens in the lumbosacral region. After class, I'm recommending you go into your anatomy and physiology book and read about piriformis syndrome on page 371. If you haven't already when you took those muscles, it's a good read. Okay, because piriformis syndrome, probably one of the more common things you'll treat. You've probably already heard everybody complaining about their sciatic. Okay, I hear about it pretty much every day at my Zumba class. So a lot of people complain about that, and a lot of the time it's just tight piriformis. So just a recommendation. Oh, no, it's not because they have to miss Zumba because of their problem. Zumba did not create the problem. Is don't be afraid of Zumba. It's awesome. Okay, so just read that on your own. Okay, cervical strain. Now, in the textbook, she calls it something that at our school we tend to frown upon. Okay? Okay, we don't like that term whiplash, and I'll tell you why. Okay, if you go to, oh, why am I missing it? Oh, look at the bottom, the picture, figure 3.61 at the bottom of 144. This is a part of it right here, okay, in this picture. So They also call it cervical acceleration deceleration injury. It's a broad term used to refer to a mixture of injuries, including sprains, strains, joint disruptions, bone fractures, herniated discs, nerve damage, and traumatic brain injuries are all seen with a cervical strain. We like cervical strain, okay, because that's what happened. They have a strain in the cervicals. Whiplash is what created it. Like, it's like calling something car accident. You know what I mean? Like, you had a car accident and it caused you to, like, break your leg or something. But you don't call it car accident. So whiplash, like, yes, you have a whiplash, your head moves back and forth, but do you see where I'm going with this, you guys? Like, does it make sense to you? Like, calling it a whiplash is calling it after the mechanism of injury rather than what the injury is. Right? So at our school, we tend to frown upon calling it whiplash. Like I said, it's like calling it car accident. So we call it cervical strain. Okay? And the reason I chose this picture is because you can see as the head goes into hyperextension, these muscles in the front, including your platysma, your longus colli, your SCM, your scalenes, these muscles are not meant to be whipped back like that. Okay, now a lot of the time it has whipped forward as well, but these big muscles in the back, like your traps and your, I don't know, muscles in the back. Oh, I'm so tired. Ooh, you toboggan accident. There you go. You have a toboggan accident. That's good. Yeah, see, you don't name it after the mechanism of injury. Anyway, levator scap, all the muscles in the back here are postural muscles. And we're going to be learning about, like I said, muscles, and there are different types, right? And postural ones tend to be the slow oxidative muscles. They have a lot of stamina, okay? So when the muscles in the back get injured, they repair pretty quick. They have a really good blood supply. They repair really quick. These muscles in the front, not so much. They're smaller, they're more picky, and everybody massages the heck out of the back of the neck, and they don't want to touch the front of the neck because it does make people nervous, but that's usually where the trouble is. Okay, so when you learn about the cervicals, that's where you learn a lot about treating these guys in the front. We got the digastric here. It's usually damaged, the platysma, the scalenes. Longus colli is deep in your neck. So some of these muscles in the front really need some special attention, and but you also have to really know what you're doing, okay, because it really makes people nervous when you're digging into the front of their neck. Okay, so you will learn about that, but let's not try to call it toboggan accident. Again, there's a really good section in your anatomy and physiology book about cervical strain, pages 312 and 313. So again, you could read over, it's an actually quicker section in your A&P about whiplash injuries, so I'd like you to read that over after class. And I also found, I think that's the end, right? Yes, okay. I also found this for you guys, so I've included the link in here where it talks about the common injuries that massage therapists sustain. Okay, soft tissue injuries. Excuse me. Okay, so it's from Massage Magazine, Preventing Common Injuries Sustained by Massage Therapists. So typical. Gotta put your ad in there. Okay. And so I thought you would enjoy this article about how to protect yourself from some common injuries and repetitive strain injuries that massage therapists live with. So again, in the PowerPoint, I've included that link for you so you can avoid a lot of the things that can happen. Okay, so I'll be loading this right after class. So that's just an introduction to some of the soft tissue conditions that we'll be going over in more detail, obviously, in class in April, and then in our evening class, and then in May, hopefully, we can just do some treatment. Okay? Sound good, everybody? No, I don't. I know. You had to listen to me sniffle and sneeze again. Bless your hearts. All right, so that's pretty much all I got for you tonight. And I just really want to go to bed. So how about you guys go have a good night, and I will see you next week for NeuroFizz. Okay? I hope to. I'm going to do a steam right away. All right, everybody. Thank you for your attention. Make sure you do that reading in the Fizz book. It'll help. Okay? Is this upcoming seminar exam weekend? No, not specifically, no. I think you might have something, but not my classes. Nope.